wanted to do to start with really though was just to take a step back from not what's inside, showing you what's inside this commissioning toolkit for those of you that aren't familiar with it, but to talk a little bit more generally about the information and data and intelligence that you may need to support commissioning. And just to sort of take you through some of the data that's out there that will link into some of the messages that Stephen and Andy and Jane had been talking about this morning around the commissioning support pack and where that information may actually be. Okay, Jane put this slide up, which is the 5 core objectives of NCIN, which started back in 2008 as a result of the cancer reform strategy, where probably for the first time from a national perspective there was a green light given to the importance of cancer information, cancer evidence, really to support services and to support outcomes, and I think really recognising the importance of good data and good information to understanding what's actually happening in the service, because until then, although a lot of us were trying to promote it, there was still a lot of perhaps poor data out there, or people not quite knowing where to go and look for the data. So one of the roles of NCIN was to try and provide this sort of end-to-end support for cancer informatics, right through from what information should we be capturing through the service, and right through to then, and how do we use that data to inform and help you to understand services and support, improve services, and ultimately hopefully improve outcomes. So I think one of the key roles for all of us in NCIN and with our colleagues at the Cancer Action Team and many of you in this room is for us to really understand what your requirements are. And they may be different depending on the role you have or the organisation you're sitting in. And one of the things that became very clear to me on Tuesday over some of the discussions was, you know, we're having a lot of discussion with the clinical commissioning groups, but you too may be in consultation with some of the commissioning support services who may be the people that are accessing a lot of this information for you. So it's sort of horses for courses as to what level you may be looking for information. But what I think is important is this quote here, that actually we can only be sure to improve what we can actually measure. And from an NCIN perspective, sitting with access to national data, is we can only share with you what we can access. So although there are lots of the quality standards that Andy talked about that are very valid and will have real impact on services, a lot of that information either isn't available to us centrally or is actually very difficult to use to pick out some of the subgroups of patients they talk about. So what you'll see here is probably going to be the sort of top level information that you can access, but recognising that we will then need to supplement it with local data as well. This is sort of picking up the key messages that Stephen and the others have already talked about around improving outcomes for cancer care. We're really looking around saving lives. I think Stephen mentioned the saving 5,000 lives to be comparable to our colleagues in Europe, or 10,000 lives to be comparable to the best in the world. We obviously have to look at providing and ensuring that we are using services and providing value for money. There is no new money around, so if we want to enhance services in one part of the service, then we may have to disinvest in other parts. So again, it's sort of how do we balance all of this together, and at the same time ensuring that patients, and at any point any one of us here could be a patient or a user of the service, the experience and the quality of life that goes along with being a cancer patient or using NHS services. So I think we have all got to understand a whole range of things, irrespective of whether we're sitting as a provider of care or a commissioner of care or looking at performance, or sitting in the centre where we're trying to sort of grapple with lots of those things together. We have to understand what the population is that we're actually serving. If we are commissioners or in that contracting commissioner landscape, what do our patients actually look like? What do we actually need to buy for our patients, which may be very different if you live in the middle of London compared to whether you live in parts along the southeast coast or northwest, northeast. So we need to understand our requirements, we need to understand what our services are out there and what they actually look like and how they're configured, and are they configured to the most appropriate setup for our population. We need to understand what the patients want, what the public want. Most of us want specialist expert care, but we also want it in our own town or as close to home as possible, and that's often a dilemma, I think, for all of us, Commissioner or provider. And as I said before, we need to understand how much it will cost, and if we make changes, where we make them, and what will be the impact of that. So what I want to look to start with, just to pull out some of the data sources that have supported the data or the messages that Stephen and Jane have shown earlier, and give you an idea of where it is. Okay, most of these messages have already come through. We know we live in a time where the population is ageing. We have increasing risks of cancer, often associated with lifestyle as well as age. So we're seeing increasing incidence of cancer, but we're also seeing increased survival for many cancers, which means by default we have far more people living with or beyond a diagnosis of cancer. So again, we're starting to move into areas where we're starting to look at the impact of survivorship, long-term side effects, long-term conditions that perhaps we weren't looking at 10, 20 years ago. The data you can see here, this has come off the CRUK website, but you would see similar things on NCIN website and the UK Cancer Information Statistics e-Atlas. So again, this sort of information is probably available in a number of places on open websites. We also know that the stage at which we're diagnosed will affect our survival, and that we're seeing reductions in mortality for some cancers. So you will be able to find incidence, mortality, survival data of all cancers and groups of cancers, probably very openly across the website. Stephen showed you this, how do our outcomes compare internationally. This has come from a paper in the Lancet. So some of you may have heard of this data, but actually never actually seen the original paper or been able to get access to that original paper. There's probably a link from our website to it, but again, it's often where do I go to find some of this information. This is a piece of work that was done in collaboration, some of our colleagues, I think, with people at the London School of Hygiene. I'm not sure this has ever been published anywhere. Somebody in our team may correct me. There's a few nods going on around the table down here. But if we're going to match the best of the world and look to be avoiding or saving 10,000 lives every year by 2014-15, then this is the sorts of numbers that we are looking at for the different cancer areas. And I know lots of networks have modelled this sort of data on your own populations and your own profiles of cancer incidence. So this sort of data, actually, you won't find anywhere unless you're picking it up off slides that you see people like us presenting. But it's often very useful to have a feel for what impact some of the NADI initiatives or national key messages may have on your local populations. Another piece of data, again, some of you may not have seen this one. This, again, was a peer-reviewed paper. Again, lots of us may not have accessed it. This was in the International Journal of Cancer, looking at why might our survival be poor in the UK, looking at different age bands along the bottom. So I've got to put my laser pointer up. But if you look at the interval up to 1 month post-diagnosis, huge excess of deaths for the English population compared to Norway and Sweden. So there's something, what is it about our population that makes us different here? Whereas if you survive to 1 month, that difference starts to disappear. Again, key information probably for those of you as commissioners when looking at your local populations, but data you may not have had access to. Stephen mentioned routes to diagnosis. Again, we've got some peer-reviewed papers coming out on this back into the summer, sometime this year. Those of you that have accessed the commissioning toolkit or have seen data briefings from the NCIN may have seen this data and may have accessed it. Others of you may not know where to go and find it at all. And this is looking at how the patients actually access the service with a view to providing more information and knowledge to support the NADI initiative. And as Stephen mentioned, around a quarter of our patients come through the emergency route. So although the data are available, again, it's a question of do you know where to find it? Have we made it visible enough where some of this information can be found? Just moving on sort of swiftly through the patient pathway, if you like, looking at surgical resections. Key part of all the messages being given out to commissioners is around transforming inpatients, enhanced recovery, reducing bed days, service close to home, etc. This was some work again done by our analysts, and this time it was published not just in the Times, as you can see here, I was going to say last March 2011, but also appeared as a published report. There's some hard copies around, as well as on the NCIN website. So again, it's out there, but have people seen it? And this work was suggesting that we see quite a major drop-off in surgical resections as patients get older. Again, there may be a number of reasons for this. This work wasn't case mix adjusted, but maybe around comorbidities, frailty of those groups of patients, or it may purely be that we still see the impact of age affecting what treatments patients get. More information, again, this was published in the Gut, so another peer-reviewed paper looking at 30-day mortality across all the providers. This time it's colorectal services. Some of you may be very familiar with this way of presenting data. Others of you may look at that and think, what does this actually telling us? I don't intend to go into it in detail, but what it's looking at, each of those dots is an individual trust. Anything above the top line is saying they've had a higher than expected 30-day mortality. They are statistically different from their peers. I think there's 5 trusts in that cohort when this was published, and there's 2 or 3 that have a lower than expected 30-day mortality. Now these things are quite important when looking at local services and looking at variation between services and over time. Again, this information I think is available on a colorectal atlas run again through the NCIN website or the NICRIS North Yorkshire Cancer Registry website. But again, it's would you know where to go and find some of these data? And again, we've seen the patient experience data around what does the population feel about their care, and the patient experience survey that the DH ran. And this data, again, you won't be able to read it here. This is openly available on the Department of Health website. So what I've shown to you is a huge amount of data, well, just the tip of the iceberg really of all the data that's actually out there, but across a whole range of different places where you would find it. Those of you that have analysts working with you may well have people that actually will go around and gather all this information up and bring it back to you. But the question for us always is, do you want good ways of the data being signposted, either from a particular website, ours preferably, or do you actually want to be able to go and find all this information yourself? And perhaps we can come back and explore a bit of that shortly. So these are the areas that I've just sort of touched on that we all feel are going to make a difference as we move forward with the Improving Outcomes Strategy for Cancer and looking at how we can improve outcomes. But there's a huge amounts of information available, and it's in an awful lot of places. There's probably another 20 or 30 places where I could have picked data from to show you. And it comes to you in a number of different formats. Some of you will like hard copies, some of you will like Excel spreadsheets, some of you like an interactive tool that you can get in and really get your hands dirty on. So it's really what do we need to be providing to support all of you? So how do we get it to you? Okay, I've just touched on this really a little bit, and again I'm going to come back to some of these questions at the end before we go into the commissioning toolkit. And I think what would be of interest to us, and the answers aren't black and white I don't think for any of these, but should we be looking to produce more interactive electronic tools for people to go in and look at their data of their providers or their populations, or do people actually still want documents, even if they're PDFs that you can download? What are people most comfortable with? We also run into lots of challenges around should we be looking at cancer as a condition, or when do we need to start dropping down into the different cancer sites, breast, colorectal, lung, etc., and when do we drop down even below that for urology into prostate, renal, etc. And that again is a real challenge for us, is when do we start dropping down to some of those groups which actually the numbers are quite small, so the robustness of the data then can become quite variable. But as commissioners or providers of the service, often you need to know that granularity of information. And then of course this whole issue about should information all be in one place, should we leave, I mean it will always appear in 101 places, so should we get smarter at how we signpost you to that information that you might need. This is a slide, I don't apologise for it, it's about 6 years old now, and those of you that have worked with us on developing the commissioning toolkit from the beginning, from back in 2007, will remember us using this slide where we started to map out, talking to commissioners at the time, what do you really need to know about your services to commission cancer well? One of the key messages to us was we actually don't have a lot of time for it. we may only have a week or so in a year to commission all our cancer services. So again, for us, it's sort of focusing what's going to be the real wins for all of you. But a huge amount of information and metrics and indicators that people wanted to look at. So the discussion then was, do we want a one-stop solution? Well, from my colleagues before, you know, we are offering you some of that already, where we're actually bringing data from about 20 different cancer sources into one place for you to go and ferret around in. But there are still a lot of challenges, and before we move on to the toolkit, because we started that, I haven't got a clue what time we're going to have to end this session. But there are some challenges for us, and these are some of the questions. Again, I'm not brave enough to use the iPad after Tuesday when we were using them, but to sort of throw out some of the challenges for us and some questions really for yourselves. We feel that we need to be sharing information with you around understanding your population, so the cancer burden in the area that you are commissioning or providing services for, and that you need to understand the local services. So that's looking at information on both the resident or geographical population and on a hospital or a provider population. We think we need, or people are interested in seeing benchmarked information and information over time. Where does my trust sit in relation to the other services around me? Do I want to be considering whether I move services from one hospital to another? Always very unnerving when you're working in a provider environment, but by looking at benchmark data you can get a feel or have that discussion with your local organisations of why do things seem to be performing differently. And then what is the role of the new or the emerging commissioning support services with those of you that are working in CCGs, and who should we be talking to in addition to yourselves about making sure the information is right. The other issues that we run into, and I think Andy touched on this briefly, is around the timeliness and the quality of data that's available to us. Some of you will remember a few years ago when the government were talking about we need to publish and polish data. We mustn't get hung up on everything being 100% accurate. Now, for those of us that come from the sort of academic analytical world, we get a bit nervous when we see that, but I've worked probably half my career in the academic world, half in the NHS, which has a slightly different, perhaps a more pragmatic view about we need to know what's happening now. It's nice to see what happened 3 years ago, but we also need to see what's happening in the services in the last 18 months or so. And clinicians too, if the information is too old, will immediately tell us that clinical practice has changed, or there are new people in their team and their service bears no resemblance to what was happening 3 years ago. So for us it's getting that balance right. Are we collecting and reporting the correct information to you? If there's things you're looking for you can't find, and we don't know whether it exists, the chances are it probably doesn't. That sounds a little bit arrogant, but I guess what I'm trying to say is we've probably got enough knowledge of what's out there that if there's stuff missing, then we have to work out how we can get hold of that information. Everyone too seems to be providing commissioning support. A lot of us go to meetings with the charities, with the colleges, with some of the other organisations, and everybody is talking about we need to support the new commissioners, we need to provide information to them to understand our particular cancer area or our particular area of expertise. I was under the impression until Tuesday that those of you working in the new CCGs were actually awash with all these guidance, but I was actually informed at lunchtime that actually very little of that has got through to you, and they think partly that's because actually the cascade mechanisms probably aren't in place yet. But again, I think for us it's how do we make sure we bring some of this together, or we're at least working together with some of our colleagues on this area for you. And making sure that where we are producing dashboards, profiles, using metrics and specifications, that they are very similar, that we're actually all pulling from the same standards, whether it's from NICE, from the service specifications, that we're not just making them up because actually we think that might be nice to look at, because that will just create and add to the confusion. And Jane touched on too the challenge that we're all beginning to realise, and you did the exercise around what is probably one of the simplest pathways for breast, where different groups may be commissioning different parts of that service. and we've had a number of discussions with different site-specific groups around how this may look for head and neck, for brain surgeries, for brain tumours, and for other cancers where you may come into a local service and then go to a specialist service. And how do we report that information back to you when you might want to see those two parts of the service as separate entities? Or do you just want to see the part you commission, and if the commissioning board or the specialist commissioners are involved, you're not interested in their part? So for us, there's something about what does a good whole pathway look like, and how do we provide all that information back to the right people? So I think I'm going to, so I've got a few questions here for you, but can I use 5 minutes or so, Stephen? I mean, I think we'd like a bit of feedback from some of you that have either tried to look for some of this data. Have you found it easy to find? Are there places where you go routinely for it? What sort of support or information do those of you that are actually going to have to access some of this want from organisations like NCIN and NCAT? Everyone's very quiet. I'm just delaying going on to the live toolkit. This is my delaying practice.
Hi, I'm a superior rare cancers lead. I think the issue I have, and obviously we haven't seen the new version, so it may be that it isn't such an issue. But generally speaking, I've not been able to use the Cancer Commission toolkit to answer the specific questions we have. So, for example, where it's a rarer cancer and you want to triangulate with a population that's not linked to one cancer network, or what exactly was happening at which hospitals, we found it very difficult to answer that kind of question.
Yeah, and I think you're right, Ursula. I mean, we've made quite a lot of changes in the toolkit, which I'll show you. I don't think we've managed to bottom out some of that yet. There are certain cancers it's much easier to target first, but I know we need to be looking at how we pull out some of that data for specific groups of cancers. Any others? Do people find it easy to find the information you're looking for? And where do people tend to go for it? You don't have to say it, the NCIN website. We'd like you to, but you don't have to. Anybody going to name where they go looking for data? Lady at the back.
I think there's 2 points. Sorry, I'm Jill Scott-Moran from NHS Surrey. I'm a Cancer Commissioner. I mean, if I want detailed level data, then I always go to my cancer network because I always find them to be particularly helpful. I have to say that because they're sitting next to me.
And I used to work in that network too. So
but I think the key thing is that as a commissioner, if you want to affect change, you've got to be able to affect change at a detailed level. So having high level information is all well and good to be able to look at it and say, well, okay, it gives me a trend as to areas we may go and look at. But actually, if you want to change something, then you've actually got to have the detail.
And the detail being the providers.
Absolutely. You know, you need to take it down to what cohorts of patients it is you're looking to be able to target, where they are, where they're being treated, what the conditions are. And if it's too high level, then it's nice as a trend line, but actually it's not much practical use.
Yeah. Well, hopefully what I'll be able to show you is data that gets down to provider level or PCT level in the toolkit. Yeah. It's the lady here.
Thank you. I'm actually from the same network, but also work in South West London as well. And I'm a cancer network pharmacist. And it's interesting because actually what you need to remember is that there may be other people than the traditional people that are actually involved with actually having to access the data. And I sort of found out about the NCIN website, which I actually think is very good, so through a circuitous route, through my cancer manager, in fact. So I think there could be quite a lot of people who actually need information and data who aren't even aware or familiar with what is actually out there and what the restrictions are and what the limitations are. One thing I will emphasise is that we do need up-to-date data because treatment pathways do change radically and they change very quickly because especially when I'm looking at things like chemotherapy and potentially where patients are actually going to be, it's no use giving me data that's actually 3 years out of date. I need it 6 months, a year ago. So even though it's not perfect, I would rather have up-to-date data with the caveat that it does need to be treated with caution.
Yeah, thank you. I mean, I think we're very aware of that message, that what we've got to be getting at is as close to real time but valuable at the same time to report it back to yourselves. I mean, I think we recognise that locally you will always be able to get much more timely data from your local providers yourself. What we're feeding back to you is how quickly can we get some of the national, so the SOS returns, I think you can all see within 2 or 3 weeks of the end of a month, may take the fastest I think we can get hold of that is 3 months through the rapid HES route. So there's always that sort of balance for us. Okay, you're now waiting for me to set myself up to fail, aren't you? Okay, let's move on and try and get into the commissioning toolkit. Again, I'm going to do a bit more death by PowerPoint first. Again, I'm just playing for time here. Those of you that are going to go into the toolkit, though, you might want to go in now if you haven't been logged out, which I think I might have done. What we decided to do when we could see the importance that commissioning was going to have for cancer was to try and bring together all the different sources of data that were available to us, either already within the public domain or that we could access through the NHS routes, into one place and make it available, make it as timely as possible, and also enable you to drill down to your local providers and your local resident populations, and where possible to also drill down into different cancer areas. I accept, though, it still doesn't go quite far enough for some specialist groups. When you go into the toolkit, and I promise I will try and go in a minute, this is what, once you've logged in, at the minute there are 2 versions of the toolkit, one for employers within the NHS, where there is potentially identifiable disclosive data in there. We had a lot of discussion about that early on, but the view from the commissioners was we want to see where there are 1 or 2 patients going through a particular part of the service. There is a second part of it which is sharing all the data we felt when we set this second section up could be put into a less restricted version, which many of the charities and other commissioning groups have access to. We're currently looking at that now with a view to taking that off completely and making as much data as possible as we can available to the public on an ongoing basis, but we'll let you know when that happens. When you first go into the toolkit, you'll see now, for those of you that have been in regularly over the last few years, we're now trying to tie this up to the commissioning support pack concept of key messages, service specification and service profile. Interestingly, I think on Tuesday when we did this presentation up in Leeds, all 4 of us had the same slide in it. Interestingly today, we've all taken that slide out, which showed you that sort of triangulation of those three things together. But you can see them on here. Or maybe there's a later one. Okay, so there's a section on the key messages, and we'll go into there in a minute. The service specifications that Andy talked about in the profiles, and then there's a section where you can start to deep dive and actually go in to see a lot of the data as it's updated either on a quarterly or an annual basis. So you can get into focus data. This is just looking at changes in mortality rates since 1997. On the right hand side, you could start to select whether you want to be looking at it by SHA, network, PCT, or if it's a relevant indicator or chart for a provider, you'll be able to pick the different organisations you wanted to look at. You can also select on here different tumour types, different years and different age groups, and all those will group the data according to what you select. And you can set it up with your own favourites. So if you are in the Swish network and you're interested in particular organisations, you can save those, and wherever you go in the toolkit, it will always return their data to you. And Andy mentioned briefly the profiles, and in a minute we'll go in and we can just actually move around them in an interactive version. Right. If I just show you this bit first, then I promise I will go into the toolkit. When you go into the key messages document, the reason I'm going to do it on a hard copy is actually downloading these takes a bit of time. And you click on the key messages, it will come up with that there are 3 documents in there. I don't know if you can you read this at the back? One is called key messages, one is about user involvement, and one is the Cancer Commissioning Guidance that Jane Whittam, I think, mentioned earlier, which is an interactive PDF that was written in collaboration with our colleagues at the Department of Health around what are the key questions to be asking of particular services. And there are 3 documents in there that you can download out of the toolkit, and as we write and develop and get involved with more of these documents, or we hear about them from across the country, then we will put these into the toolkit so they're all in one place for people to access. All right, I'm now going to have to jump in. might do. Too late now. Okay, this is the login screen, and the URL is cancertoolkit.co.uk. And when you first go in, I think Andy called this our Daily Mail disclosure. It is asking those of you that have access into this to behave responsibly with the data. We can actually track where people are going through the toolkit. And because now there are increasing numbers of Excel spreadsheets that you can download out of here, we do have to make sure that we cover all the required governance arrangements around sharing data. We should have ticked. Okay, so now we're in the main section, and here's the key messages bit that I showed you earlier. And if we move across, you can see the service specifications. So if we go into the service specifications, I don't know if I'm going to use the laser pointer or the mouse. And in here you will see there are 3 service specifications in there at the minute, but as more get released to us, we will add all those in. And I think underneath here, this is the copy of the breast one. I think Andy had them outside, but you can just download them and take them for yourselves. But they will always be in here, and you will always be able to see which is the latest version. If you want to ask questions, please do. We might have 2 versions running here. Okay, if we now move into the profiles. Got frozen this one. Okay, you'll see when you go into the profile section that it's a bit of a misnomer, and I think we need to change the name of this, because not only will you find the profiles that Andy talked about in here, but also some interactive data extracts and analysis that we've done, as well as some PDF reports on particular work that colleagues have done as well. So if we first go into the profiles, you'll see at the minute we've got 3 profiles listed in there. GP practice profile. For those of you working out in primary care, have you all seen your GP practice profiles? Is there anybody in primary care who hasn't seen their practice profile? Okay, we can probably share it with you later then. What we were asked to do, again, and this was around beginning to support the new commissioners, was to put together what information was available that we could look at practice level. So Sean, who's disappeared from here, sitting down here, worked with us to produce 8,500 GP practice profiles. And I think I've got them open. Oh no, it's the, oops. Okay, if we go into the GP practice profiles, what you're seeing here, I might nip back into the PowerPoint in a minute, is that there are now 2 years worth of these. They were first produced in 2010. And we updated them in 2011. So you can actually go in now with your primary care teams and look at whether changes may have happened over time. You can download the file, or you can download PDF versions. When you go in here, what you can ask for is to select all the practices within a particular PCT. I'll just pick one at random. And then we can download it. Now, if you want to download it, you are asked to, again, just to reconfirm that you will treat the data within the governance rules that we're providing it to you with. And at the bottom of here, you can see that there are a number of documents that will support you in looking at that data, either in telling you what the indicators are and how we've actually analysed it and prepared the data, or how to actually read and interpret the profile. Stephen, you might have to keep an eye on the time for me, because I could get lost in here. About 15 minutes, okay. The reason they're at PCT level is that, again, this was purely a size thing for Excel, but what we're hoping that in future iterations where we start to build them more interactively through the toolkit, you'll be able to see them all. But if you wanted to look at all 8,500 of them, you'd have to download 152 PCTs first. When you go into it, for those of you that haven't seen this before, the same format to what Andy showed you, but let's just bring so you can see the spine chart. I guess people can't really read them here, but it's the similar sort of format through about the demographics. What does your practice look like in terms of the types of I was going to say patients, but the population you serve in terms of age, gender, deprivation, ethnicity, areas around what's happening with cancer screening, around coverage and uptake for your population, cancer waiting times, how many patients are you actually referring through the 2-week wait route, and then looking at special cancer areas, so looking at breast, colorectal, lung and skin, a bit about diagnostics, but the same approach. And at the top here, you can see the mouse going up there. When you go in here, you can select, hopefully it's going to work. For some reason it's not. They gave me a new version of Microsoft yesterday, that's typical, isn't it? If you just look at the spine chart, you can see the figures changing as you pick different practices within that PCT. So there's a lot of information in here, and I know the NADI initiatives are using a lot of these and working with some of the practices around what these profiles mean. And interestingly, when you start to look at some of the combinations of indicators together, you start to really understand what might be happening in a practice. When I shared this with the GPs in my practice, we noticed that the number of patients being referred for 2-week wait for breast and skin were really, really low for the population that they cover. And what we also realised at the same time was that the screening vans were in the area, so actually a lot of the people were perhaps going to screening rather than coming into the primary care. And we also have a GP with special interest for skin. So there were reasons why this practice was actually looking very different from its colleagues. Let me try and go back into the toolkit. Andy showed you too the service ones. The PCT one is very similar to the GP one, it just aggregates the data up at a higher level, but that is created within the toolkit. I won't bother with the sort of the detail, but that gets updated every 3 months when the new cancer weights data come out. So again, that one does change every month, whereas the GP one is just an annual change. Again, Andy showed you the colorectal one. I've got the breast one open here. I haven't got a GP. Is that GPs again? Yes. Can I fire it? Excuse me while I find it. This is the one actually, sorry, I've picked up the one for breast here. But again, similar format, and you can select the different organisations that you want to see. And we've had 1 or 2 requests from some of the new commissioning groups around could we actually group different providers together to be looking at a whole population, or could we start to cut the data in different ways. So at the minute you see the breast teams, there's 165 different MDTs, but they're quite keen, some commissioners, to see these in different ways. And if I just pick on one, as Andy said, we shared this data with all the service before we went live with it, and I'm looking for one in particular. It's not going to show it for us. What you see on some of them up here, when you go into them, if there is something specific about the data that the trust has actually come back to us. We had one trust that said they knew they had a real problem with their HES coding, and the data was making them look very different from everybody else. So we've actually not gone back, we can't go back and change the HES data, but what we've done is put a comment into the toolkit to say the data for these indicators are wrong, or we think they're wrong because of this reason. So again, when you're looking at it and having that dialogue with your providers, when you're looking at these data, we're trying to give you pointers where the MDTs or the trusts have told us there's something strange about it. And we're hoping, I'm not sure it's coming out in June or September, to have a similar profile for radiotherapy. Service specifications, I think we'll move on from. And now I'll take you into some of the detailed area that some of the charts, I hope. Okay, when you go into the chart section, so again, those of you that perhaps haven't been in for a while will see this has changed quite markedly. What we've done, in the old version of the toolkit, it was following the chapters of the Cancer Reform Strategy. So you'll see at the top, up here, it mentions what we're calling DH chapters. What we've done now is actually reprofile it to really follow the cancer pathway. And when you click on any one of these, so we start at incidents, I'm not sure whether you can really read them. When you click on anything, it will open out, and in blue it will show you what charts are actually available within the toolkit, and will give you a little bit of information about what is there. Is there any particular area somebody would like me to go into? That's probably more than... okay, let's look at... So this is looking now at age standardised incidence rates, and because this is a population-based analysis, you'll see that we can group it by SHAs, networks or PCTs, and we can, and this is looking at all the, at the minute we've got all the SHAs marked in here. If I ask for it to name them all, it will put the names of all 10. Should do, up on here. So you get a clear picture of where your SHA sits in relation to others, or we could have selected it at network or PCT level. So if you've got it set up as a favourite, it will automatically return to you. If we wanted to go further and look at a particular cancer site, let's look at lung, for example. Please do it. Oh, it's done it, thank you. So again, you can now see the profile, and we've got the northeast SHA here, southwest SHA at Ireland. So again, you can see it if you hover over them. May not work on here today with the screens. It will bring up the numbers of patients that it actually have been included in that analysis. I won't do it, but we could change the year, so you can actually go right back down to 1996. And you can look at different age groups, and all those different selections you can switch on or off yourself. On the right-hand side, sorry, left-hand side here, there's also, I'm not sure you can, it's quite showing it all on this screen, what's a section around the source of the data, so telling you where the data have come from, telling you anything about that data source that might be important for you to understand, as well as an indication of some of the methodology that's been used to calculate these particular charts. There's a commentary which is giving an indication of what they're actually showing, and then gives you the chance at the bottom here to put your own comments in about your local populations or your local services. Now I've got to remember how to get back. And then there are others. There's a lot in now about radiotherapy, and you can see there's a lot of new charts. So again, what we've done here too is bring in where there are relevant reports that might be of interest to you. So for radiotherapy, there's the National Radiotherapy Implementation Group report and the model service specification. So where we can, we're linking things across through the toolkit. So you'll find that radiotherapy service spec both in the specification section but also in the radiotherapy section. So hopefully you can start to find things linking together. And then there's a number of different charts in here. This one here is looking at age profile of LINACs, something that a lot of the different services are beginning to look at to make sure that their business plans are in place to ensure they can replace the older LINACs. This is looking at all LINACs across the whole country. And the pink area is where a LINAC is 8 or more years old, which I understand from talking to colleagues is when you start to want to replace them. And you can see we've got 30 LINACs, 10 years old, 19 that are 11 years old. And if you start to pick different networks, where shall I go? Central, South Coast. It will tell you the profile of their own LINAC, so you can go in and look at different ones, and you can actually then select the where there may be more than one centre within a network. Start to look in the individual trusts as well. I'm going to go back to the PowerPoint now. In fact, that went, I think, well, from here it went better than perhaps it might have done. The reason I'm going to go back into the PowerPoint is that we've also got in there, under this section around the data extracts, information around a lot of HES returns, a lot of reports around your hospital episode statistics and length of stay at provider level. So you can actually go in and look at the trusts and what their average length of stay, etc. I won't open any of those because there's an awful lot of them. And then information as well about laparoscopic colorectal resections, radiotherapy fractions by cancer site, routes to diagnosis, which again I think Stephen or Jane mentioned. And when you go in there, you can download, again, a very interactive spreadsheet which has all the information for your networks around the routes to how did your patients access the service, and broken down by cancer site. And there's also information there looking at their 1-year survival, 1-year outcomes. So again, there's a lot in there. And then there's the section around PDF reports. There's a lot of work done by the cancer nurse specialists with Cancer Action Team around workload. And I think the number of whole-time equivalents per 10,000 patients, etc. All that information is in there that you can go in and access. The latest, just to finish really, the latest thing we've put in there is what we're calling some quarterly briefings. And we were asked by the National Radiotherapy Implementation Group to be able to give them a quarterly update, or whenever they meet, of what was happening for radiotherapy across the country. So this goes back to what the lady was saying earlier. You know, this is top-level data, but what we've got in the toolkit is all the underlying data as well. And what we've generated from the data that's in the toolkit that you can go in and look at provider level is a report that generates itself each quarter that we can send, that you can access and we can send to the national team. And what we actually asked was that the national leader for radiotherapy, Tim Cooper within the Cancer Action Team, and our radiotherapy information lead, Peter Hoskin, write a commentary on this. And these are the sorts of things that are in there, and you can see their commentary at the bottom. So they're giving us the very latest position on where radiotherapy services are every 3 months. So they're looking at attendances per million population, number of operational LINACs by provider, the age profile of those LINACs, which I've just shown you, the 31-day waits for radiotherapy, and beginning to look at fractionation profiles by cancer site. This is probably the most timely data that we've now got in the toolkit being pulled together for yourselves to look at each quarter. And then I've shown you how we can drill down into the underlying data. We've made a lot of changes in this, I think, for those of you that may have started using it in 2008 to now, but I still think there's a lot of other things we can put in here, and obviously we want to support you, so anything you think should be in here, come and have a look, tell us, advise us, so that we can make sure this is the one-stop shop, if you like, for supporting you with commissioning in this new NHS. So I'll stop there. And how to register? That's a very good question. I've put our websites, I think, on here. Right, the URL to get on is, say, www.cancertoolkit.co.uk. When you go on, actually I could go back to being interactive again, hang on. If you don't already have access to it, there is a registration button. Right. Logged in, that's what I want. Just take me out. Underneath it, right here, it says not registered yet. So if you're not registered for it, if you go in here and register, if you're working within a PCT or a provider trust, I think all those organisations have been given access to this, so you should just be able to go and register, and it will, by return, send a password, a username and password to your email address. But we do have to have an NHS address for it, so anything like Gmail or doctors.org, we can't send those back to you, so we do need an NHS address. For some of the primary care teams, some of the practices are already registered, some aren't. We do need to have a senior partner or someone authorise all employers to have access into the toolkit. But if you can't, but if you register and your practice is not in there, then it will automatically fire off an email back to the practice to get that sorted for you. If you have any more problems, then come back to us and we'll sort it out. But it should be instantaneous for most of you to get into here. Those of you that are in some of the new commissioning support groups that don't have NHS addresses, we're putting people in on a named patient basis, providing you can prove who you're working for. So for anybody in the room, it should be relatively easy now to get into the toolkit.